see my screen?
Yes, sir.
Okay, thank you. Yeah, again, good morning, everyone. So today we will continue our class about the introduction to nuclear medicine. And then in this course, the second one actually, we will discuss about the therapy of cancer. And just to remind ourselves that this is the second course of the two courses explaining and describing about the nuclear medicine. If you remember last week, we discussed about the introduction of nuclear medicine, the meaning of the nuclear medicine, and the history of the nuclear medicine. And then we discussed also about the instrumentation in nuclear medicine, for example, planar, spec, and PET. And all of these are meant to be the diagnostic of cancer. And today, we will discuss about the introduction to internal dosimetry, and then this is related to the therapy of cancer. So this is our topic today, and then this is the learning objective. So we hope that after this learning process, you should be able to first express the method of radionuclide therapy in your own words, including relevant types of radioactive decay. And then we hope that you know, name and explain the process of dosimetry in nuclear medicine, including the explanation of the MIRD formalism. And then last but not least, we hope that you're able to name and explain the differences of radionuclide therapy or molecular radiotherapy compared to external beam radiotherapy and brachytherapy. And then as always, yeah, so please note that additional readings as given, for example, in the last slide is strongly recommended. Yeah, I mean, if you remember last week, I already show you several references that you can use for additional reading. So if you are interested, please check and then please explore it yourself. So again, why internal radiation dosimetry? So we know that when we use radiation, right? So we're gonna deliver something that can destruct the cell actually. And then for this therapy in nuclear medicine, where we inject the radioactive substance inside of the bloodstream of a patient, then we can imagine that this radioactive substance will move around the body and then can give radiation and can destruct the cell. So therefore, if we're talking about the dosimetry, dosimetry is just a term used to show the process where we calculate this radiation absorbed dose. And then what is the benefit of doing this? First, for the therapy, of course, yeah, I don't have to write it down here. We should know why we need to calculate radiation absorbed dose for any types of radiation therapy. So I believe that we already know. Anyone, can you give me your comment? Why we need to calculate the radiation absorbed dose? I believe that you already can, I mean, have a good idea why this is very important. Anyone, please?
Because we want to prevent any harm to the person that any harm to the person.
Yeah, yes. Very good answer, Hasid. Thank you very much. So you introduced the term of harm. So it is very good because you know that we can imagine if we have radioactive substance, this radioactive substance will move around the body of the patient. So there is a possibility that this can also destroy our healthy organ, right? For example, our liver, our kidney, our lung, and so on. So therefore, we need to prevent that. Thank you so much, Hasif. So we need to make sure that we can really deliver the dose, in this case radiation absorbed dose, that can destroy the tumor, but we also need to make sure that it won't make anything bad to the patient. In this case, destroying the organ at risk, for example, yeah, or healthy organ. So therefore, in the therapy, the dosimetry is very important. And then in diagnostic, it is very important as well. Yeah? Even though the importance level is not the same with therapy. In therapy, it's very, very important to calculate the radiation dose. But in diagnostic, yeah, it's important, but not that important. Why? Because usually we use the lower amount of radiation. Yeah. And then here we perform this determination of switch activity to balance potential hazard to patient. And then this is what we call as the diagnostic reference value. And then for the staff and the helping person, it is also important because we can determine the absorbed dose according to law. So usually in every country, we have a law showing that for certain condition, yeah, we need to have a patient with certain number of the radiation absorbed dose. So we need to make sure that this patient would not get a very high radiation passing this limit number from the government, for example, yeah, from the government body. So this is also important, again, for the staff and also helping person. So this is the overview of our class today. We will discuss about radionuclide therapy. So we will discuss about the type of the radionuclide that we use for this type of therapy. We will also discuss about radiopharmaceuticals or endotherapy. And we will also discuss about the determination of the activity that we use for the therapy. For example, in this case, I will discuss about two different methods that usually people use. The first one is the dose escalation trial, and then the second one is the dosimetry base for individual patients. And then we will discuss also the medical internal radiation dose committee. And of course, for the dosimetry in radionuclide therapy, we will discuss about the standard, the advanced, the challenge, and also the opportunities. And in addition, we will also discuss about the influencing factors on biodistribution and some references. So in molecular radiotherapy, again, basically we have a patient. And then for this patient, we inject radiopharmaceutical drugs. Yeah, we already discussed before what is the meaning of radiopharmaceutical drugs. So it contains three different things, right? If you remember. So the first one is the drug itself, plus the radionuclide or radioactive substance, plus the chelator, the chemical materials that can hold together the radionuclide and also the drugs, so that they can move together inside of the patient body. So we inject this radiopharmaceutical drug to this patient, and then you can imagine that what happened inside of the patient body. So again, this radiopharmaceutical drugs, because we inject it to the bloodstream, then it will distribute it through all of the organ, internal organ of the patient. So you can imagine that if we have these radiopharmaceutical drugs shown by the yellow color, then it will distribute it to the lung, to the heart, to the liver, to the kidney, intestine, and so on. And then let's say that, yeah, we have this liver, and then we would like to calculate the radiation absorbed dose inside of the liver. Wait, just give me 1 minute. Okay? Okay, so let's continue. So you can imagine that if we have all of these radiopharmaceutical drugs, yeah, inside of all organ, that if we would like to calculate the radiation absorbed dose inside of the liver, then we need to calculate the radiation happen inside of the lung, for example, that can give a radiation to this liver. We also need to calculate the radiation happen inside of the kidney. That could also give some radiation absorbed dose to the liver. Because you can imagine that if this radiopharmaceutical drug is located inside of the organ, then the organ become the source of the radiation itself. So you can imagine that this liver again will get the radiation from all over the organ, yeah? And even inside of the liver itself, we know that we have some radiopharmaceutical drugs inside. So this can also give some radiation to the liver itself. So it's very complicated and it seems like very unsafe, right? So that's why the question is whether it is safe or not. And then this is again what we need to be grateful that we learn about physics, because in physics we learn how to deal with this. So if you are working as a physicist in a hospital, then one of your job is to calculate and make sure that the patient will get this condition of safety if they get this type of therapy, of molecular radiotherapy. Yeah. Then the radionuclide therapy itself, or people also name it as molecular radiotherapy or targeted radionuclide therapy. Basically, again, we inject the patient with radiopharmaceutical drugs. So as you can see here, that the radiopharmaceutical drug is shown by the red color. Yeah. And then after we inject this to the patient body, it will distribute it through all of the patient body. And then, of course, this is what we hope, actually, yeah, that first, all the drug will go to the target, and in this case, the tumor and also the metastasis of the tumor, and then it will stay there indefinitely, we would say, yeah, until the tumor or its metastasis get destroyed. And then all other radiopharmaceutical drugs will be cleared from the patient. So this is what we hope. So therefore, we need to two things that we need to make sure from the radiopharmaceutical drugs. The first one is the accumulation. So it is very, very bad. If we have a drug, we inject it to the patient, then it will distribute it to all part of the patient body forever. Or it will distribute it only to the healthy organs. So it is very bad, because then we will get a very high radiation absorption dose to that healthy organ. So we need to make sure that we have an accumulation where inside of the tumor and also its metastasis. And then the second one is we also need to make sure that the radiation that we have, in this case ionizing radiation, have a short range, because you can imagine that we have a good accumulation here, right? But the radiation is very broad, is very low. So there is no need for us to have a good accumulation. You understand what I mean? Because the radiation will go through all of the patient body anyway. So we need to make sure this, and of course, we also need to make sure that we have high energy, because we would like to destroy the tumor, right? So this is the reason why we choose beta and also alpha particles radionuclide for this therapy. So again, by definition, yeah, radionuclide therapy, we inject radio-labeled substance, and then we also need to use radionuclides with a short range of ionizing radiation. In this case, for example, like the alpha, beta, and also auxer emitter. And then the aim is to have a selective irradiation due to accumulation in target organ. So here, how to get the accumulation? We can get it by using the specific transporter or receptor system for the organ-specific accumulation. So for example, we would like to use this type of therapy for radioimmunotherapy, for example. Yeah, for example, we're talking about the leukemia, for example, yeah. And then we know that our tumor have a lot of transporter in their surface, cell surface. So therefore, here we can use antibody, because this antibody can target the transporter. So this is how we get the accumulation. And then what type of radionuclide that we use here? Again, alpha or beta, yeah. And then we already discussed this before last week. as far as I remember, where the alpha emitter is basically we have a certain atom, and then this atom need to create this radiation, yeah, of helium-4 to be able to make it stable. Yeah, for example, Ra to Rn. And then for the beta emitter, it means that we need to change, yeah, one neutron into one proton to one electron to make this atom to be stable from Cs to Ba. And then the other electron is just basically we have radiation, for example, from the outside. And then this radiation will give some energy to the electron in this shell. And then this electron will have some energy to move, yeah, and separate itself from this shell, this one. And then, of course, this atom become unstable. Then the electron from this shell need to move to the vacancy shell here. So, of course, because we have different energy between this K shell and also L shell, then we can imagine that this process will create radiation as well. And then this radiation can be absorbed by the electron in certain position, for example, in M cell. Then this electron will have some energy that can be used to move from this shell. And then this is what we call as the electron housing. And then this is the information about the energy and also the mean range of the movement, yeah, for all of this radiation. So for the beta particles, the energy is around 1 mega electron volt, the alpha is around 5, and the other electron is around 0.001. So you can imagine if we have a heavier particle, then of course the energy is higher. And also the mean range is shorter. Yeah. And then this is the radionuclides that usually we use in nuclear medicine. For example, here we can use iodine 131, and then this is usually we use it for thyroid cancer, for example. Yeah, the half-life is around 8 days, and then the maximum per molecular weight of the beta energy is around 606. And then this is the maximum or the 90% range movement of the particle. And this one is the gamma energy. So we also use this lutetium and also yttrium, yeah, for the therapy. And then why? Because the energy is high, yeah. And then also we can label these to different types of drugs. For example, for neuroendocrine tumor, we can label these two to the octreotide, for example, or PSMA for the prostate cancer, for example. And then as you can see here, yeah, the range are different. So for the yttrium, we have a broader range, yeah. And for the lutetium, we have shorter range. So this is the reason actually why people tend to choose lutetium more than the yttrium. Because you know that we would like to have a short radiation, right? To make it a very local radiation. So that's why this lutetium is very good compared to the yttrium. Yeah, but the other reason why people also use lithium is because the energy is higher actually compared to this lutetium. So it depends on the type of the therapy itself. Yeah, sometimes people use lutetium, some of the time people use lithium. And then you know that for calculating the absorbed dose, yeah, and then also performing the treatment planning, the symmetry, we need to have this radionuclide with the gamma energy. Why? Because only gamma energy that we can measure with diagnostic imaging. So therefore, as you can see, iodine, no problem because we have 82%. Lutetium is also no problem, yeah, because we have some gamma energy, even though not that high, yeah, on the 6 to 11%. But yttrium, we don't have it at all. I mean, we have it, but the number is very, very small. So maybe around 0.00001% for the gamma energy. So that's why for the dosimetry is quite challenging and difficult for yttrium. Therefore, usually people using indium 111 for calculating the dosimetry of the yttrium. Yeah. Why? Because as you can see, their half-life are similar. Yeah. And also the important thing is because they have the gamma energy very, very high number. With this very high number, then of course we can perform diagnostic imaging. Diagnostic imaging, we can use it for the dosimetry of the therapy. So therefore, usually we use indium to mimic the biodistribution of the yttrium here. So the radiopharmaceuticals, we can use different types. Yeah. For example, for the radioiodine therapy, we don't need the drug. We just inject the radionuclide. In this case, iodine 131. For the radioimmunotherapy, we use antibody here. For the peptide receptor radiotherapy or PRRT, we use peptides. For the palliation of bone metastasis, we can use SR or SM. And for radiosynoviortesis or RSO, we can use yttrium, we can use ER, we can also use RE colloid. And then one of the important note is, remember that the biodistribution or the biokinetic, or in another word, we can say that how the radiopharmaceutical drugs moving inside of the patient body depends only or mostly on the compound and only a little bit on the attached radionuclide. Because you know that we inject two things, right, to the patient body. The first one is the radionuclide itself, and then we combine it with the drugs or radiopharmaceutical drugs, and then we have a chelator. And how these radiopharmaceutical drugs moving inside of the patient body mostly affected again by the biodistribution here by only the drug. Yeah. Okay, so before we continue, I have some video to show you. Wait. Just give me a second. Okay, I have two videos here. Can you see my screen? And can you hear
It's
something?
hard to describe.
Yes.
Okay, thank you. So let's watch.
It's hard to describe how much it affects your life, not being able to leave the confines of your house. Okay, so this is a 2002 Thunderbird that I restored. They only made 60,000 of them. This is the car that I go on all my road trips with, and 3 years ago, I had to stop doing that 4 years ago because the symptoms, the cancer symptoms, made it impossible to do it.
Hi, Mr. Sherman. Nice to see you.
Hello, Jeff. How's it going? How are you?
When we met Bob, he was essentially homebound, had stopped traveling, stopped seeing friends. He had really given up all the things that he cared for or was interested in.
The carcinoid syndrome has a bunch of different symptoms, but mine, you have diarrhea, constant diarrhea, so I couldn't do anything. I was stuck at home. I was a prisoner of my home. I just stayed there, didn't go anywhere. So I've had 2 liver resections down in Winchester, and they've taken 4 or 5 tumors off the liver. Then they were going to do another liver resection. I said, you know, I've had 3 operations now. I said, I don't want to do this again. And I started doing some research. I found the department in Hopkins, so I called up and said, I want a second opinion on this surgery. And I went up and I saw Dr. He. He said, well, we don't think surgery is appropriate here. We got something we think's better for you.
Theranostics is a new way to manage cancer. It's a new way to treat cancer, whereby we find a very specific molecular target, and then we first image the patient in order to determine whether they have the target. And if they do have that target, then we will come in and use a molecular radiotherapeutic that hits the same exact target as the imaging agent did. Once the specific target is identified, the therapeutic agent is injected intravenously into the forearm. Then it navigates the bloodstream and finds the exact location on the tumor. The therapeutic agent is then internalized in the malignant cell, where it's able to deliver a localized dose of radiation directly to the affected cell, rather than more broadly treating the disease and the location in which it presents.
With the first treatment, about a month after the first treatment, things got dramatically better. And maybe 2 months, I was out having dinner with my son and his wife again. It doesn't sound like a whole lot, but you know, when you can't do it, it's going to a restaurant's a pretty big deal.
So Bob has done really well. We see him every 6 months. We do a scan with the diagnostic agent to see what his tumors look like. But given the remarkable response he's had so far, we expect that he'll do well.
Well, the reason why we think theranostics is a game changer is the tremendous benefit to the patients in terms of their quality of life. Radiology is normally thought of as a set of imaging modalities, but more recently we're doing more advanced functional techniques. So radiology is increasingly becoming in itself a therapeutic modality.
4 years ago, before it got bad, I take road trips. I've been across country a couple of times. I've been, you know, just about every state. So Dr. Solness came in and we were talking, and I told her, I said, you know, I'd love to take these road trips, and I hadn't been able to take one. And I told her about the Grand Canyon and all that stuff. And she said, well, hopefully you'll be able to do that now. And if you go, you better send us pictures. And the Lutathera was the last hope for that. And luckily it worked.
Yeah, so this is one of the videos. You can imagine that how science, especially, for example, in our case, physics, can really become a game changer for the patient life. So you can imagine that this is one of the example of patient that can really get the benefit of such therapy. Traditional way, they just do the surgery. Many surgery, but it's not good, because you know that it's painful, taking so much effort, so much energy, and a lot of money as well. But then if we just do this, inject it to the patient, although we use a very dangerous stuff, in this case the radionuclide, that can really give radiation everywhere, but it can save life if you really can manage it nicely, if you can really calculate it nicely to make sure that the patient again can increase the quality of life and also cure the cancer, hopefully. Okay, so that is the first video. And then I also have another video that I would like to show you.
Theranostics is a really revolutionary concept. Every patient actually is different, every therapy is different, and to find out the right treatment for the right patient at the right time, that is actually what is theranostics.
Theranostics is the idea of diagnostic and therapy together. If you can look at it and see it via a diagnostic probe, then you can use a therapy probe and treat it. So the idea is, if you can see it, you can treat it.
There are always two parts. One is your vector, your ligand, which is targeting the tumor cell. And the second part is a radioisotope, which is stably bound to this compound. So we can use different isotopes for imaging, for example, for PET-CT or SPECT-CT.
Okay, just a small remark to remind you about what we already learned. So basically, this is our drug. Okay, so the radiopharmaceutical drugs contain this red color, purple color, and also the yellow color. So here, this one is just the chelator. Okay, This is something that can hold together the ligand and radioisotope to move together, okay? It is like a seat belt, I already told you, right, in our previous meeting. And then the second one is the radioisotope. This is the one that can give us the radiation. So this is the radioactive substance, yeah? And then this ligand is basically the one that can helping us to find the target. And this target is actually located, yeah, in the surface of the cell. And in this case, hopefully the surface of the cancer cell. So you can imagine that this part, what we call as the radiopharmaceutical drugs, which is injected to the patient body. And then after that, hopefully after some times, this ligand can meet the target, and then they can bind. Yeah, and then while they bind, this radioisotope, the radioactive substance, can give the radiation that can destroy the cancer. Okay, hopefully it's understandable for you. Okay, let's continue.
So we can use different isotopes for imaging, for example, for PET-CT or SPECT-CT, but also for therapy using beta emitters or alpha emitters.
I came across Dr. Baum at a medical conference in Toronto where I was looking for advancements in treatments for my own disease. 4 weeks later, I was on a plane for my first gallium-68 DOTA scan in Bad Berka, Germany.
The Diagnostic Center Bad Berka was originally founded in 1997, so 20 years ago. The initial focus for treatment was actually neuroendocrine tumors, and the first patient was actually a very young patient, and he had a rare tumor, paraganglioma, was very far progressed, so he could not walk anymore, and by our treatment he was able to return to what is very important for German boys, soccer playing.
Since then we have applied more than 20 different types of novel radiopharmaceuticals, first in human application, and also we have developed various protocols in where we can personalize therapy for patients.
The treatment we are using for neuroendocrine tumors is called PRRT, peptide receptor radioligand therapy, which means that you use a specific peptide, in this case a somatostatin analog, labeled with a beta emitter or with an alpha emitter for targeting specifically the neuroendocrine tumor cell.
Here we can actually visualize the tumor bulk in the patient. We then also characterize the different physical and physiological parameters of the patient, kidney function tests and blood tests, and then we can tailor the amount of the radiopharmaceutical that we are giving to the patient.
Patient typically undergoes in the first phase of treatment in PRRT 3 to 4 cycles. We really look at a variety of parameters, patient-specific as well as tumor-specific, and then restage the patients. Of course, the patients can be again offered another cycle of PRRT if necessary.
We are tailoring the treatment activity precisely to the situation of the patient itself. And according to the theranostic principles, we can also perform post-therapeutic imaging on the ward itself.
We are using an in-house developed dose protocol. We call it Bad Berka dose protocol. Our main goal was to develop a dosimetry method which is practical in our daily clinic.
This is one of the medical physicists. So she is actually a physicist, yeah, someone that graduated from physics, and you can see that she's working for the hospital. Yeah, and then doing all of this stuff about the modeling and so on to improve the calculation of the radiation dose. And then her work is very, very important for the whole protocol of the therapy. So again, your major physics is very important in different area of application. So one of them is this one for nuclear medicine. Yeah. Okay. So let's continue.
Clinical routine and to make the dosimetry available for each of our patients.
We started treatment of patients here in this center in 1998. We are now treating more than 400 patients with neuroendocrine tumors per year.
from originally diagnosed as being stage 4, I'm now what's classed as a clinically stable disease. I'm here in the hands with the experts, so I can't say any better than the gentleman's helping me, because him and his team have done minor miracles in my opinion.
We started actually with treating neuroendocrine tumors, but then another very promising ligand was found, which is called PSMA, prostate-specific membrane antigen. This is a structure which is heavily expressed in metastatic and hormone-refractory prostate cancer.
We've been doing the PSMA radioligand therapy since 2013 now, and in fact we were the first in the world to perform the lutetium labeled PSMA radioligand therapy.
In prostate cancer we were very impressed by the drastic treatment effects.
Again, so you can imagine, yeah, this is what we see from the patient before the therapy. Yeah? So here, the black color represent the accumulation of the radioactive substance inside of the tumor. So you can see that the black color is actually the tumor. So we have so many tumor here, very unfortunate patient. Yeah. So you can see the tumor is everywhere, and also the metastasis. So it is very, very bad. So how we can do the surgery for such a patient? Almost impossible, in my opinion. How can we do the surgery? Do we need to open many different parts of the patient and take it out one by one? No, it's impossible. Some of the tumor, they are moving together with the blood. For example, like leukemia, how can we take out that tumor from patient body? Again, it's impossible. But then, as I told you, in physics, we can use this radionuclide and ask them directly to find the tumor itself and to cure them. Then you can see here, this is the result. Amazing, right? So it is almost clean 100%. Yeah, we never know. Maybe there's still some small tumor, yeah? But most of the very bad tumor is already gone. Yeah, it's very, very amazing in my opinion. And this is how science can do to treat the patient. Okay, yeah, let's continue.
Treatment effects. So there were patients, coming in on a wheelchair, and after 1 or 2 treatments, they were driving their own car to our center. In 2011, we started what is called the Theranostics World Congress, and this congress has meanwhile traveled all around the world to India, to Australia, and it will be in Jeju in Korea in March 2019, and this is actually the first proceedings book we published from our congress in 2011.
When I first made my visit to the clinic, not very many people in the United States knew about theranostics. I started working to make access available around the world. The FDA just approved January 25th, 2018, lutetium-177 dotatate for the treatment of neuroendocrine tumors in the United States, and it was approved in 2017 in Europe.
I think theranostics has a great future. It actually is now also extending to other indications like pancreatic adenocarcinoma, also to lymphoma, to lung cancer, colon cancer, breast cancer. So it's really becoming a part of the mainstream in oncology.
If you can get to this clinic, the Bad Berka clinic here in Germany, and have the grace and good fortune to be under Professor Baum's care, it's the best place to be, seriously, because the man's a genius. It's as simple as that.
Yeah, again, yeah, so I would like to show you that as a physicist, you need to be proud. Because again, this is just a small part of application of physics that you can pursue for your career, yeah? Where you can see that the physics can be used to really save human life. You can imagine that we are working not only to explain why the apple getting gravitational force, for example, and so on. No, not only that, but we can also save lives with physics. So again, physics is very important, especially for its application. Yeah, and this is only one of them. So I believe that in this creates class, you already learn also about the application of physics in different part of area. Yeah, for example, like the materials, yeah, instrumentation, and so on. Okay. So again, hopefully that you can be proud of your major, especially in physics. So okay, let's continue. Wait, just give me a second. Yeah. So again, what is your job? Yeah, in the hospital then. If you're working as a medical physicist, then what should you do in the hospital? So one of them is to calculate the activity, yeah, the activity of the radiopharmaceutical drugs that needed for certain patient. And then how we calculate this activity? At least there are two different types of method that you can use. The first one is what we call as the dose escalation trials. So this activity determination is basically analogous with the chemotherapy. Yeah. So we calculate the amount of drug, or in this case, the activity per mass of body weight or surface area. So in this case, we already have some information, yeah, from the literature or from some society, yeah, of nuclear medicine in the world, for example, from Europe or from America. They already have this number, certain number of megabecquerel, certain number of megabecquerel per kilogram, or certain number of megabecquerel per body surface area. How they calculate this actually, yeah? How they can come up with this number? So they perform again what we call as the dose escalation trials, or in fact, actually this is activity escalation trial. How we do it? So basically they perform this for many patients, and then they created different groups of patients. So for each of the small group, we have around 3 to 6 patients. And then for different group, yeah, we inject one group with a certain number of activity, and then we increase the activity for different groups step by step. And then if the activity creating severe toxicity, then we need to lower it down by one step. And then in the end, we're going to have an activity, the optimal activity in the end. Yeah, this is what we want to have. But the problem is, let's say if you're working for a hospital, right? Someone or one patient coming to your place, and then you said that, okay, so just use this megabecquerel number, or we can scale it simply by using their mass or the body weight and also the body surface area. But this is just a number that we collect based on the literature from this study, from different population that coming maybe from different country, most probably, which you can imagine that we are the same species, right? We are human, I know, but the problem is we have a different habit of eating something, for example, habit of taking some exercise and so on, right? You understand what I mean? So therefore, this number may not be applicable for all people in the world. Maybe only applicable for certain population only, but not all patients. Yeah. So if a patient comes to your clinic, we just use this number, the number that derive from other patient population from other country, then it may not be optimal for our patient. So we can say that the interpatient variability is neglected. Yeah, for example, the pharmacokinetics, we don't care about it. The sensitivity, we don't care about it as well. Then this may lead us to the under or over treatment of a patient, and this is not good. So therefore, yeah, medical physicist, you also need to know how to calculate the activity that need to be injected to the patient for an optimal therapy by calculating it individually. So the objective here is to achieve a prescribed individual tumor absorb dose while minimizing the normal tissue toxicity. It is similar like the external radiation therapy. So here, what we need to care about is the individual measurement of the radioactivity. Yeah. Some information that we need to also take into account is the spatial and also the temporal distribution, and also calculation using electron density distribution of absorbed dose per injected activity in tissue. In this case, the output is gonna be the gray per megabecquerel. So that we can just use this number, yeah, that we calculate individually for certain patient to calculate the optimal injected activity. The procedure is we apply the radiopharmaceutical activity and amount. Yeah, in this case, we apply it for the diagnostic, and then we measure the biokinetics, yeah, the number of decays in the considered organ, for example, the organ at risk, and also the tumor, and then we can create different protocol and strategy for calculating the optimal absorbed dose based on the prescribed dose from the doctor, medical doctor in this case. So what do we need to quantify? So the radiation absorbed dose in tissue or in gray, yeah, how many energy joule per kilogram absorbed by the tissue? We need to quantify at least 3 components, yeah, that we need to quantify and also consider. The first one is the radiation physical component. This is related to the emitted energy per decay and also the absorbed energy in spatial distribution, and also the geometrical component. Yeah? For example, the mass and the geometry of organs, and also the relative position between irradiating and irradiated organ, and also some biological component. For example, like the biokinetics and also the biological effectiveness. Okay, so let's discuss one by one what we need to understand for calculating the organ absorbed dose, radiation absorbed dose. So the first one is, yeah, we administer the activity, right? And then when we have this radionuclide, for example, the radionuclide that we use for the therapy is RE 18675 with a half-life of 90.64 hours. Yeah. And then we understand that, I believe you already learned about this, yeah, from the university, that one type of radionuclide can create a different mode of decay. For example, there is a possibility that this RE will move through this beta minus type 2, and then will move here, and then it will create the gamma type 5 and stable, gamma OS. Or it will move to gamma 4 branch, and then creating gamma 1 branch, and then stable become OS. Or this can also move to the electron capture mode of decay, move here, and then create a gamma 1 decay and become stable W. So here you can imagine that one radionuclide can create different possibility. It is similar like you having a coin, right? When you toss a coin, of course, it is almost impossible that you can always have a good guess of what is the side that would be on the top side if you toss a coin. So it is almost impossible if you need to predict 100 times and all predictions are correct, then you should not working for physics, I think. You need to work for something else because you already know the future, right? So therefore, yeah, it is impossible to predict the number that you will have. for this certain condition. So the one thing that we believe or we know is the statistic or the probability of getting something on the top side of the coin, for example, whether let's say one side is the tail and one other side is the head, for example, right? We just know that for getting the tail, the probability is 50%, and also getting the head. So that is the one thing that we know for sure. The statistic we know for sure, but in the term of the probability. So it is similar like this one. Yeah, we do not know whether at certain point we're gonna have the mode of decay moving to this beta negative type 2, and then moving to gamma type 5. I think we can say that it is impossible. The only thing that we know is, okay, we have all of this possibility of the mode of decay, and then we know the percentage of the possibility for each of the branch of the mode of decay. So that is one thing that we need to understand from this. Okay. So this is can be done using a simulation of a random number. And then, have you heard about Monte Carlo simulation? I believe you already know about this, right? So basically, Monte Carlo simulation is just a type of simulation that simulates a random number. And then by having this random number, then we can have the probability of certain condition. So this can also be done for our radionuclide. For example, this is the output of a software. Yeah, the name of the software is Olinda. Olinda can help us to simulate the radiation mode of decay. And then, for example, here we have a rhenium-75 186. And then, as you can see here, yeah, we have the half-life of 90.64 hours, and then the decay mode is either can be the beta negative decay mode or electron capture. And then in this column, you can see we have different types of radiation mode of decay. For example, beta negative type 3, beta negative type 4, gamma, yeah, and also the electron capture, KL, and etc. for different electron shell. And then this is the particle per transition number. So this is just basically showing the probability of each of the radiation. And then the energy particle, yeah, so we can also get the energy, the unit of a mega electron volt, how many energy for each of the mode of decay. And then we can also calculate the other product, yeah. And then you can imagine again, by having this, then we can simulate what happened inside of the patient body. This is actually what I like the most from nuclear medicine, because, you know, we are not a magician or someone with a paranormal brain or ability, but we can see what is happening inside of the patient body, and that is very, very amazing in my opinion. Yeah, so that's why this is what I love and what I like the most from this nuclear medicine. Okay, so we can calculate everything here. Okay, and then that is the first part that we need to understand. Yeah, whole mode of decay, the energy, and etc. Yeah, about the physical characteristic of our radionuclide. Yeah. The second one that we really need to understand and learn is the geometrical component. So let's say that you have radiopharmaceutical drugs, right? And then it will move inside of the patient body, and at certain point it will be located inside of your kidney, for example. And this is the kidney of a patient. And then this arrow showing the radiation direction. So of course, because it is located inside of the kidney, then this radiation coming from the radiopharmaceutical drugs can also irradiate the kidney itself, but it can also irradiate all other organs outside of the kidney. For example, we have this liver in blue color. Then because we have radiopharmaceutical drugs location here, then we can have the condition where this radiopharmaceutical drugs can create some radiation, then can irradiate this liver. Okay. Here we can also use Monte Carlo method, to calculate the number of CIJK. This C is showing the fraction of emitted energy of mode of radioactive decay I in source organ J. This is the source organ J, which is absorbed in organ K. For example, this is the organ K as the target. So in principle, one must take into account the inhomogeneous spatial distribution. So because you know that when we have a kidney, right? And then this kidney will get some radioactive drugs inside. But then the distribution of this radioactive substance inside of this kidney would not be homogeneous actually. It should be inhomogeneous. But this is not practical. So therefore, for this, we can assume that it is homogeneous, even though not really homogeneous, but research show that this method can also approximate a very good result for the absorbed calculation. So some approximation that we use here, it is written in Stabin et al. For the Mirados publication. First, the approximation that we can use is the activity is distributed homogeneously within the organ. And then the second one is we can also use a standard phantoms. Here it means that we use a fixed organ mass and also organ geometries. But you know that when we have a patient, of course, the organ size, in this case, the mass and the geometry are different with the one that we use in our phantom, the virtual phantom. It is not the problem because then we can just scale it, scale it down or scale it up. It doesn't matter. We can just take into account the real volume and then we can scale it based on the volume that we can get from our phantom for a certain organ. Okay. And then this phantom, we have different variety of ages, and even we can have a pregnant liver. Okay. And then here we also use one approximation that the absorbed dose created by the beta radiation have a range 0. So it means that exposition only within the source area. And the last but not least, one of the important part that you need to calculate as a medical physicist in the clinic or hospital is the biological component. And then the parameter that you need to calculate is the time integrated activity coefficient. The outdated name is the residence time. This is the symbol. And then how to calculate this? This is basically just the number of decays in organ J, the decays of the radionuclide, divided by the administered activity. So how to determine it? So we need to perform measurement of the time activity curve in respective tissue followed by integration over time. So that is the reason why the gamma decay percentage is very important, because before we perform the therapy, we need to perform the imaging first. So this is why you heard the term of theragnostic, right? In the video, if you notice, theragnostic means thera is the therapy, gnostic is the diagnostic. So it means that when we perform the therapy, we need to merge these two terms all together, the therapy and the diagnostic. We cannot perform the therapy with the individual dosimetry without information from the diagnostic. So we need to inject the patient with the gamma emitting radionuclide, and then after that we perform the imaging or the diagnostic of the patient, and we perform it several times. So for example here, 1 dot corresponds to 1 imaging diagnostic. So if we have how many dots here? 1, 2, 3, 4, 5, 6, 7. 7 dots. It means that we need to perform 7 diagnostic imaging. And then after that, that is your job to create the region of interest, taking the activity out from the image that you get from the diagnostic imaging. And then you can create this curve, yeah, for different organs. For example, you get this information of the curve from the bone marrow, yeah, liver, yeah, kidney, and also urine. And then why we need the red bone marrow? Because the red bone marrow, in this case, this is one of the example, the real data from the patient for the RE188 anti-CD66 that the people use for radioimmunotherapy of leukemia, for example. Yeah? And then the target is actually the red bone marrow. We know that if patient losing their red bone marrow, then they die. But because this type of tumor, they are distributed mostly in the red bone marrow, then this red bone marrow become the target as well. Yeah. And then why we need liver and kidney? Because liver and kidney usually we have liver and kidney as the organ at risk. The healthy organ that getting relatively a high amount of radiation absorption. So we need to make sure that the liver and kidney is safe during the therapy. And then the last one is the urine. Why? Yeah, because usually we get the information from the urine, right, to diagnose the patients. Then we can create the curve like this, yeah, for each of the organ. And then after that, we can calculate the time-integrated activity coefficient by calculating the area under the curve of each of the organ. So how to calculate the absorbed dose? Then we already have all of the parameters that needed for calculating the absorbed dose, but how we calculate it? So this method is actually introduced by the Medical Internal Radiation Dose Committee, a committee of the Society of Nuclear Medicine in America, founded in 1968. And the members are physicists, yeah, and also physicians. And they publish usually in the Journal of Nuclear Medicine. This is the name of the journal. They have so many pamphlets. Yeah, I think they already have more than this, the number of pamphlets. But at least last time I checked, they have 23 MIRD pamphlets, 20 dose estimation reports, and also 3 books. They also have their own page. So if you are interested and you would like to see more what they have done, yeah, for this dosimetry, then you can check this, yeah, www.snm.org. Or you can also check the journal website. I think you can find it easily on the internet. Yeah? Just Google Journal of Nuclear Medicine. Okay. And then this is one of the famous publication from the pamphlet number 21, a generalized scheme for radiopharmaceutical dosimetry. Yeah. And then this is also related to the ICRP, the International Commission on Radiological Protection. In here, you can read it, and then you will get the information how one can calculate the radiation absorbed dose. Okay. And this is how we calculate it actually. So the absorbed dose in the target organ, it is just basically the multiplication product of the administered activity from the diagnostic. We multiply it to the sum of the time-integrated activity coefficient, or the outdated name is the residence time, with the S value, yeah. And then this time-integrated activity coefficient, we can calculate it as the division of the integration ADT from 0 to infinity to the administered activity. What is the S value? The S value itself is just basically related to the physical and also the geometrical component of the radiopharmaceutical drugs. we already discussed about it before, right? That here we have the Ni. Ni is related to the different radiation mode of decay, yeah, because we have different mode of decay, right, for a certain radionuclide. And then we can calculate the percentage of the probability for certain mode of decay to happen. And then this is the energy for each of the mode of decay that we have from the radiation. And then Ci is related to the geometrical component. If you remember, right, this is the percentage of how many radiation coming to the target organ from a certain source. And then we need to divide it by the mass. Yeah, this is all the information. Okay. And then this is the symmetry. If you would like to perform it in ideal way and individually, yeah, one by one, we calculate for each of the patients. First, we start with the quantification of patient-specific pharmacokinetics, and then after that, followed by the parameter estimation, and then after that, we perform the prediction of pharmacokinetics during therapy, and then we calculate the absorbed dose calculation. Here, we can add the information from the radionuclide data and also the mass and location of organs, and then we perform the calculation of the absorbed dose here. Yeah. Here we also perform the therapy planning. If needed, we can also add some radiobiological information inside. Then after that, then we perform the treatment. We also need to calculate the quality control measurements. Yeah? And then if needed, we can also move to different cycles. Okay, and so on. And here we have the kinetic and also observational model for at least the first, second, third, and sixth step. So before we continue, I have also one video. Wait. Yeah, okay, this is the one. Okay.
Invited colleague, his name is Dr. Jean-Mathieu Beauregard. We've been collaborating with him for quite a bit, even since I was a PhD student and one of mine doing basic cancer. We've been working with him. But Jean-Mathieu, why don't you introduce yourself so that people know who you are?
Sure. Hi, Carlos. Hi, Armand. Thank you for this invitation to have a chat today. I'm Jean-Mathieu Beauregard, a nuclear medicine physician based at CHU de Québec, Université Laval in Quebec City. And I have a very strong interest in all the new theranostics and in particular in personalized administration of these radio pharmaceutical therapies.
So Jean-Mathieu, can you tell us exactly what is theranostics? What is like the current practice, and what are the problems that you identify there?
Yeah, despite this ability to see where to follow the radio pharmaceutical in the body, still these therapies have been practiced for 80 years actually, since the introduction of radioactive iodine in a very empiric fashion, where all the patients receive a fixed activity. There have been only a few exceptions in the history of nuclear medicine, but currently the most practiced radiopharmaceutical therapies, such as lutetium dotatate, lutetium PSMA, we give basically about 200 millicurie per cycle to all patients.
Kirim na gedor pakai Grab Express Instant.
Sorry.
Cepat dan aman.
Okay. There are so many
Selesai.
sponsor
Enaknya
video.
bikin
Sorry.
lupa segalanya.
Okay, let's continue.
So yeah, so that's a question that many people ask me. Is a question that I have myself. Where does that 200 millicurie or that 7.4 gigabecquerel, we're basically injecting that to everybody, where does that number really come from?
Yeah, right. It comes from not much, actually. 200 millicurie has been popularized with radioactive iodine, iodine 131, although it's a very different radioisotope than lutetium. This number has prevailed, and lutetium has been started with 200 millicurie portions, and then based on data from only 5 patients back 20 years ago, it has been calculated that giving 4 of these cycles would yield an absorbed dose to the bone marrow of about 2 grays, or not exceeding 2 grays in only 5 patients. And then it started this way, and 20 years later, it has been approved by the FDA, Health Canada, and in Europe with this regime.
So it's almost like it was like the default, and people just went with it, and now we're almost stuck with it. And I think it's worth revisiting. So a question, Jean-Mathieu, would be, I often catch myself and others saying injected dose, and I stop myself and others and say, you shouldn't call it injected dose, you should call it injected radioactivity. The question is, if we're giving fixed injected radioactivity to people, are we giving the same dose? Are we delivering the same absorbed doses to our patients?
Yeah, absolutely not. Why? Because there's a high, if not a huge interpatient variability in specific absorbed dose. Specific absorbed dose is the gray per GBQ of injected activity. And we've seen that with lutetium dotatate. For example, there's about a 20-fold difference between patients receiving the least and the most absorbed dose to their kidney for any given injected activity. Same goes for the bone marrow. And we've got also similar numbers with lutetium PSMA, where the absorbed dose to healthy tissues varies by at least 1 order of magnitude, if not more. So yes, giving the same activity to all patients results in a very variable treatment between patients.
I mean, these are mind-blowing numbers, actually. So we sort of sometimes don't even want to think about it, right? But it's there. And of course, we become idealistic. Maybe we'll talk about it later. We become idealistic and say, well, how good can we do it anyways with dosimetry? But the truth is, if we don't do dosimetry, this is a massive range of doses that are being delivered to our patients.
So from what we're seeing here, do you think it's valid to say that we are under-treating most of our patients?
Yes, because even the patients receiving the most absorbed dose to their critical tissue, like the bone marrow or the kidney, still, for the vast majority, tolerate the treatment very well. So it means that perhaps we could increase the absorbed dose, and to achieve this, we would increase the injected activity in those patients receiving less radiation per administered activity. And also, there's this dose-effect relationship that have been demonstrated many times in different series, where we see that indeed the more radiation is delivered to healthy organ, the more toxicity can be seen. For example, here we have a relationship between the bone marrow dose and the drop in platelet counts, which is a very sensitive biomarker of side effect to the bone marrow. And also the tumor dose response has been shown with lutetium dotatate PRT, where when the tumor receives more dose, it shrinks more, which is kind of obvious, because the active ingredient being radiation, the more you give, the better the effects. And this has been also demonstrated with lutetium PSMA 617 in the Australian series, the responders, the patients responding to the therapy, receive a significantly more higher tumor dose than those not responding.
So sometimes when people say, Jean-Mathieu, that there's not enough evidence, I mean, how do you take that? That clearly you're showing some evidence, but is a part of that lack of evidence the fact that it's a chicken and egg thing, that we're not doing too many dosimetry studies to even add more evidence to this? So what are your thoughts about that?
Of course, it would be desirable to study these relationships in larger cohorts, but considering the many results from independent cohort, it always points to a dose response, and when the results are maybe less significant, it's because the cohort are usually smaller or more heterogeneous. So the principle is there. More radiation results in more the tumor response, and also in healthy tissue to more toxicity. So it's really a balance between both. And since we're dealing with palliative treatments, these treatments so far are palliative. The more radiation to the tumor can basically results only in better tumor response. Right. But we must not make these treatments more toxic than they are. So we must control the radiation to the healthy organs.
You know, it almost feels like an ethical issue to me, the fact that we're systematically underdosing probably a good fraction of our patients because we're not doing dosimetry, and therefore they may be at the lower end of this dose response curve, and therefore not getting the sufficient care that they could be getting, right? Would you agree with that?
Yeah, absolutely. We're not giving the same chances to every patient to respond to the therapy and derive benefits.
Okay. So one of the issues that I get talked about all the time is that performing the dosimetry, we have to bring the patient a lot of times to the clinic to get all the multiple scans so that we can do the time activity curve. That basically it takes a lot of resources and
it freaks people out. It's like, right? And it's like they say, oh, 4 cycles or 6 cycles, and every cycle you got to do 3 SPECT. So that's like 12 SPECT scans. Like, who's going to do that? So
are there solutions for this, Jean-Mathieu?
Yeah, well, for quite the last few years, the single time point dosimetry has been a very hot topic. It has been the first publication in 2018, and
this is the biggest beach club in the world.
Welcome to Atlas Beach Club.
The interest has grown a lot, and with so many publications on the feasibility of this approach. And indeed, that may be a part of the solution. So basically, what is the single time point approach is to do just one scan at a carefully chosen time point. And then the uptake measure on the scan would correlate with the area under the curve, so the number of disintegration that is used to compute the dosimetry. And it will correlate even if there is some degree of variation of the actual effective half-life for the patient. So basically, it works best if the time of the scan is about 1.4 times the effective half-life of the patient, because it acts as a sort of pivot point where about half of the radiation is delivered before that the scan and half after the scan. So slight variation of the effective half-life would not impact much the area under the curve.
I remember this, Jean-Mathieu, years ago when I was first confronted by this, that the fact that you can estimate the area under an exponential pretty decently with a single time point was almost a bit shocking to me, but it's there. And of course, where you sample, would change the accuracy. So I guess what are typical those errors that we could get using this method?
Yeah, with this method, we can get about 10% accuracy for the vast majority of patients. And as we looked at in many different cohorts of patients undergoing either lutetium PSMA-617 therapy or lutetium dotatate, we found out that because now these tracers, they are both lutetium-based, but they have very different kinetics. The lutetium clears faster, the lutetium PSMA clears faster from the body, so that the optimal time point is more around 2 days after the treatment, whereas with lutetium dotatate, it's better to scan 3 days after the treatment. These are the scanning time point that would give the best accuracy to key critical organs, as well as reasonable accuracy for the tumor dose.
So I think sometimes people get idealistic. They're like, oh, it's 10 or 20% error. It's not 1% error. So let's not do it. Would you agree with that comment?
Yes, no, actually. Well, of course, when we compare to the accuracy seen in external beam radiation, which is 1 or just a few percent, it seems that the accuracy of dosimetry maybe too large. It has been reported to be about 20% or 15 to 30% or so the precision we can get with dosimetry of in radiopharmaceutical therapy. But instead of comparing with the accuracy in external beam therapy, why don't we compare with what we get with the current practice of fixed activity radiopharmaceutical therapy? As we've seen earlier, we have coefficient of variation that are in the range of 25 to 75% for critical LT organs. So that's the kind of error you get on the dose when you give the fixed administered activity to all patients.
Yeah, exactly. So instead of being over idealistic and comparing with something totally different, external beam radiation therapy, aiming for 1-2% error, the point is, what you're saying is, if we don't do it, the errors are so massive that doing it should be compared with not doing it, and it could change, those errors by possibly, factor of 5 or 10 improvements, maybe, right? With the errors that we're getting.
Yeah, we can drastically reduce the inter-patient variability in absorbed dose to critical organs, and in doing so, we can escalate in the majority of patients the injected activity and so the tumor dose.
Matiin listrik demi hemat, tahan panas demi hemat, gerah.
Okay, Jean-Mathieu, so you said a moment ago that the way we're approaching the radiopharmaceutical therapy is more on the palliative side of things, and you have it here in this slide. What are your impressions in the sense of, do you think if we perform dosimetry, we personalize this, is there going to be a point in time which this is going to become is going to move from palliative to more curative?
For some patients, at least, right?
Yes, exactly.
What are your opinions about this?
Yes, for some patients that do respond to the let's say the fixed activity regime, perhaps they could have even greater clinical benefits, and indeed for some of them maybe it's possible to achieve cure if we can escalate the tumor dose by a factor of 3, 5, or 10 in these patients. Maybe their tumors will not completely disappear. It's possible, certainly, but even if we don't achieve this, we could certainly shrink their tumor by a greater extent, or prolong their survival. Absolutely.
So I guess the message you're trying to convey is that we can really we can do things better. We can reduce this massive variability that is there, and often we don't want to admit that is there, right? Is that something that, it seems to me that that's a very important message.
Yes, actually, it's essential to decrease this variability in absorbed dose if we want to max it out to a safe still within a safe under a safety threshold, and in turn that will allow to maximize the tumor dose, and certainly giving fixed activity considering this interpatient variability does not allow to give this maximum tumor dose that would maximize the likelihood of clinical benefits to radiation radiopharmaceutical therapy. Basically, in the end, doing a fixed activity radiopharmaceutical therapy is really a treatment that is not equitable between patients because they are all different. They do metabolize the radiopharmaceutical differently, and for the vast majority of them, we're not achieving the maximum tumor dose that would still be safe for them.
Right. So not equitable. Those are really strong words, Jean-Mathieu. So thank you very much. I think we've learned from you.
Yeah. So hopefully you get some information from the conversation of some expert. Yeah. So basically, they are discussing about the individual dosimetry. So you can imagine that if we have a patient, right, then people tend to just use the fixed dose. So it means that we assume all people behave the same for their biodistribution and pharmacokinetics, and then we just inject the same amount of drug. Or we can also just use the body weight or the body surface area for tailor the individual dose. And then it is not very good, right? And then this is the job of the medical physicist as well, to calculate the absorbed dose, because this calculation of the absorbed dose individually can really improve the efficacy and also the safety of the patient. Yeah. Okay. Let me prepare my slide. Okay. Oh yeah. By the way, I need to send you this. This link so that you can fill it out. Okay, so I send you the link for the attendance, yeah, to this class. So please fill it out, okay? And then let me see, where are we now for the slide? Give me 2 minutes, okay? Okay, so hopefully the time is enough to discuss this. Let's see. If not, then maybe we can just make it a little bit faster. Yeah, so, okay, so let's discuss the step one by one, yeah? So the first one is the quantification of patient-specific pharmacokinetics. So here, it means that we need to calculate this time-integrated activity coefficient. The standard one, we can use planar gamma camera imaging and also manual region drawing. The advanced one, the tomographic imaging. So we can use here the SPECT-CT, the PET-CT, or even PET-MR for the quantitative imaging measurement. So here, this is one of the example from the software that we can use for the dosimetry, the individual dosimetry. So here, as you can see, that we perform the scan for a certain patient. And then here we have two images from one scan. This one is from the anterior, and this one is from the posterior. And then your job is first, of course, to make sure that the image is good enough. Yeah, so there's so many things that you need to check actually. But let's continue to just this quantification. Okay, so here for the quantification, you need to draw a road. Yeah, region of interest of, for example, this one is the kidney, right? You can also do this, using automatic way with machine learning, for example. So it doesn't matter. So the most important thing is you need to make sure to the medical doctor that the way you create the region of interest is good enough with the high accuracy. Okay, and then after that you will have many information here from your region of interest. And then after that, then you perform parameter estimation. Here, still we need to do this for the calculation of the time integrated activity coefficient. The standard one, we can perform fitting kinetic data by sums of exponential and also fit function selection by experience. The advanced one, actually you can use a very complicated modeling. For example, usually in our group, some of the projects are related to the physiologically based pharmacokinetics model. And then here, the best model, we can select based on the objective criterion, for example, using a KK information criterion. And also we can perform uncertainty estimation. And then this is how we do it. So after we create the ROI, right, the region of interest, drawing the ROI from the patient organ, and then after that you will have this list of different organs, for example, from the total body, the heart, the kidney, the liver, and etc. And then you need to fit the data using the sum of exponential function, for example. And then you can create then this dot line. From this dot line, then you can calculate the area under the curve. And then this area under the curve is actually the time integrated activity coefficient. So we need to do this for every organ. So for example, this is one of the examples from the bone marrow. Okay, but you also need to do it also for the kidney and etc., liver and etc. We also need to think about the temporal sampling schedule, because the standard one, we just use data sampling schedule with the rule of thumb. Usually we perform 3 measurements for 1 exponential at arbitrary times. But the advanced one, it would be nice if we can create such an algorithm that can choose optimal sampling scheme based on population kinetics. And then here, this is one of the example from 20-hour post-injection. This is the image from the patient. And then, basically this is what you do. So you perform the fitting to the data that you collected from the patient image for different organs. We also can perform some modulation of the biodistribution if needed. For example, we can use the lysine and arginine co-infusion to saturate the kidney uptake by competitive inhibition. For example, used for kidney protection in PRRT, and also we can perform individualized preload. For example, we can use preload of monoclonal antibody, peptide, and also pre-target. So this is one of the examples how physics can help us to improve the protocol in the clinic or hospital. So you can see here, without the injection of preloading, you can see the black one showing the high level of the radiopharmaceutical drugs. So as you can see here, from this patient, we have a very high accumulation of the radiopharmaceutical drugs inside of the kidney and also the liver. And this is not good, because then we have a very high absorbed dose, radiation absorbed dose to this healthy organ. And we can use this preloading. So we inject first unlabeled monoclonal antibody of 0.5 milligram per kilogram. And then you see, we can make it better. And then we can do this by calculating the number here, the optimal one, using an appropriate simulation with a physics modeling ability, of course. And then with this, we can intensify the conditioning, and then of course the therapy may become better and also cheaper. And then after that, we perform the prediction, and then we calculate the absorbed dose. Here we need the S value, of course, yeah, to be able to calculate the absorbed dose here, because we already have the A, right? We need to collect the S value as well. Here, for the standard one, we can use a whole body or organ level. And here we can also use anthropomorphic phantom S factor. Here, we can use this software. Yeah? The Olinda software is very famous. So we can use it for the calculation of the S value using the Monte Carlo simulation. For the advanced one, of course, you can improve it by adding the voxel or the cellular level. Yeah. And also we can add the information of the inhomogeneities. Here we also can add the individual S factor, convolution kernel, and also Monte Carlo simulation. And we can also add some nuclide, for example, like the alpha emitter. This is some example from the phantom that we can use for the nuclear medicine dosimetry. For example, the mid-5 phantom, very generic one. Yeah, even you cannot see the real shape of the organ, right? But this can, I mean, some people still use this. The VIP man phantom, people also use this one as well. Yeah. And then, of course, in the end, we need to calculate the absorbed dose, the predicted one. Yeah. For example, here we can use Olinda EXM software. And then the input is the residence type for different organs from the measurement. This residence time or time integrated activity coefficient we collected from the fitting process. Here we can use the standard phantom, for example, the fixed geometry. We use the male 70 kilogram, and also female. We can also use it for the child, and etc. And we also need to choose and input the physical properties of nuclei. And this is one of the examples of the output. So you will have the gray per megabecquerel number for each of the organ of interest. And we need to make a protocol to calculate a favorable distribution. And then here we need to perform the therapy planning. Yeah, the standard one, usually from the medical doctor, they give us the physical dose prescription. For example, the maximum dose for the organ at risk. And then in advance, we would like to also add incorporation of dose rate effect and also DNA repair, linear quadratic model with organ-specific parameters, for example, like the alpha and also the beta parameters. And we can also add some information about the biologically effective dose, the BED, and also fractionation. We can also, for the advanced topic, include the inclusion of additional information. For example, you know that tumor, they have different hypoxia level, proliferation level, and also the angiogenesis. So we can also add this to our protocol for a certain dosimetry and also therapy. This can be obtained from molecular imaging. And then for the standard therapy planning, yeah, so how to determine the therapeutic activity? Only if favorable dosimetry is exists. So we have this constraint from the medical doctor, yeah, we have this constraint. And then by using the output from Olinda software, the one that I showed you before, we can have a protocol where we inject an IV intravenous administration of 3.2 gigabecquerel of non-yttrium labeled antibody. Then we're going to have this distribution. And it's good, right? Because the red bone marrow, we will have 25 days. It's good. It's not passing the maximal number. The liver 7 is still safe. The kidney 2.4 below, far below the maximum number of 6. So this one is relatively good. And if needed, we can also add the radiobiological modeling. And of course, after everything has been done and good enough, then we perform the treatment. Yeah, the standard one, for the verification, we can perform the radiopharmaceutical quality control. It means that we need to make sure that our radiopharmaceutical drugs is stable inside of the blood. So we don't want to have this radiopharmaceutical drug combination destroyed. Yeah, so we need to have a quality control as well. We can also perform the planar and also the 3G imaging. The advanced one, we can perform development of routine dose control method. For example, image quantification of nuclides, serum kinetics, and also PPK model. And this is one of the example, because you know that before we perform the therapy, we perform the prediction, right? And then during this prediction, we calculate the favorable dosimetry for the biokinetic and also the absorbed dose. And then we come up with the injected activity. But then we need to make sure, yeah, because this is the result. The yellow one is the result from the pre-therapy, from the imaging, the diagnostic. And this is the result from the therapy, from the blood serum of anti-CD66. We need to make sure that really what we predict is the one that we can get from the real therapy. And as you can see here, this is the result, yeah? And we can make sure that, okay, the result is good because what we really plan is really happen in the therapy in the therapy process. So again, that's all for the dosimetry, yeah. And these are all several reference that you can make. Okay, okay, that is the end of my class today. So is there any question, please, from the student? Anyone? Any question? No? No question? Okay. So I would like to have one photo for the report. Could you please open your camera only for maybe about 1 minute or 2 minutes to just getting the photo all together for the report, please? Okay, okay, I can see here Hasif, Elisa, Mates, Muhammad Aiman, Fice, and also Ijat. Please turn on your camera. We just need about 1 or 2 minutes, yeah, for the report. Okay, we can take the photo now. Please see to the camera. 1, 2, 3. Okay. That would be all, guys. So I'll see you maybe in the next occasion, and hopefully this medical implementation of physics can give you some insight, yeah, about the importance of physics, especially in medical application. Again, have a good health always, and see you in the next occasion. So bye bye.
Thank you, Doctor.
Yeah.